Good morning, everyone, and welcome to our event. My name is Sarah Kott, Senior Vice President of Programming at The Hill, and I am delighted to welcome you all here to Medicare Drug Price Negotiation, How to Ensure Access and Equity. I would like to thank our sponsors, Alliance for Aging Research, for their support of today's event. We are here this morning for a deep dive on the impact of the Inflation Reduction Act and on the Medicare program. So far, it has capped the cost of insulin, eliminated out-of-pocket costs for recommended vaccines, and improved access to affordable prescription drugs, and got the ball rolling on direct price negotiations. When you RSVP'd to this event today, we asked you a few questions on what you would like to see when it comes to Medicare health coverage. 24% of you said lower costs, 22% said expanded coverage to include dental, vision, and hearing, 21% said expanded prescription coverage, followed by streamlined administration processes, better access to specialists, and increased provider choice. Our guest today will weigh in on all of these topics and more. But first, a few housekeeping rules. Please put your phones on silent, but you're encouraged to join the conversation. Thank you. Online, we'll be tweeting at The Hill events, and we'll be using the hashtag #TheHillHealth. Now it is my pleasure to introduce our sponsor segment. Please welcome to the stage Executive Director of the Alliance for Aging Research, Susan Peshin, in conversation with Dr. Sarah C. Collins, co-chair of the Health and Policy Committee for the Association of Black Cardiologists. Welcome.
Yeah. Okay, well, good morning, everybody, and thank you so much for joining us. My name is Sue Peshin, and I serve as President and CEO of the Alliance for Aging Research here in Washington, D.C. And at the Alliance, our team's mission is about changing the narrative to achieve healthy aging and equitable access to care. And for more than 35 years, we've strived for a culture that embraces healthy aging as a greater good and values science and investments to advance dignity, independence, and equity, which is why we're gathered here to discuss this important topic today. We're thrilled to sponsor today's exceptional program from The Hill, Medicare Drug Price Negotiation, How to Ensure Access and Equity. The Hill's editor-in-chief, Bob Cusack, will lead today's discussions with Congresswoman Barragan and Congressman Dr. Larry Bucshon. These informative one-on-ones will be followed by a powerhouse panel featuring leaders we admire from two partner organizations, a prominent business school professor, and a former Democratic member of Congress who voiced concerns about the impact of price negotiation during consideration of the Inflation Reduction Act, known as the IRA. As with any large piece of legislation, there are a lot of moving parts, and the IRA is no exception. The IRA has a number of life-changing reforms that will directly improve Medicare beneficiaries' ability to afford their prescription medications, including a much-needed $2,000 cap on annual out-of-pocket costs in Part D, a smoothing option that gives folks the option to evenly divide their out-of-pocket costs over the course of the year, a $35 monthly cap on insulin, full coverage for all CDC-recommended adult vaccines, including boosters, with no out-of-pocket costs, even if you're in the deductible phase of the benefit. So go get your flu shots and your COVID shots. And a significant expansion of Medicare's Extra Help program for low-income beneficiaries. And at the same time, there are many unknowns, as the Medicare program attempts for the first time to directly negotiate the prices for selected prescription drugs. Price negotiation alone is expected to save the federal government $98.5 billion over a decade, but whether beneficiaries are going to see any of those savings remains to be seen. The Centers for Medicare and Medicaid Services, known as CMS, recently announced the first 10 drugs that will be at the center of these landmark negotiations, and recently held a series of listening sessions on them for patients, family caregivers, beneficiaries, consumer and patient organizations, and others to share input. And we were able to participate in 2 of them, and we're grateful that CMS held those sessions. A lot of what came up in the session centered on concerns regarding access and equity, which is why we're here today. And I'm excited to be joined by Dr. Susan Collins to help ground today's conversation with observations from her real-world experience. Dr. Collins is an interventional cardiologist in Bowie, Maryland, and serves as the co-chair of the Health and Policy Committee of the Association of Black Cardiologists. Welcome, Dr. Collins.
Good morning, Sue. It's great to be here with you today.
Thank you. So let's jump right into it. In September, CMS announced the first 10 Part D drugs that are going to be subject to price negotiations in 2026. 7 of the 10 drugs treat cardiovascular disease or diabetes. What reflections can you share on the drugs initially selected, given their concentration on these conditions?
Exactly. I think it's important to go back to the conversations that occurred in Congress and compare them to how CMS ultimately acts. When the IRA was being discussed in Congress, there was a lot of conversation to build support for the price negotiation that was centered on drugs that really had sticker shock for patients. But ultimately, I don't think that intent was reflected in the first list released by CMS, unfortunately. And as you mentioned, 7 of those 10 medications treat cardiometabolic conditions, which is right up my alley. These medications help patients at a very high risk of stroke, heart attack, pulmonary embolism, deep vein thrombosis. Others are used to treat diabetes, chronic kidney disease, and heart failure. The prices for these drugs aren't trivial, but they're already heavily discounted. When I look at CMS's list, what makes it notable is that millions of Medicare beneficiaries rely on these drugs. Most were chosen based on volume and total cost to Medicare, and I get it, but what that means is the potential for harm if access is restricted is substantial. It's also important to put a spotlight on how these conditions disproportionately impact communities of color. We all know that Black adults have the highest rates of stroke, heart failure, hypertensive renal disease, as well as the highest premature cardiovascular mortality in the country. Hispanic, Black, and Native Americans are 40 to 50% more likely to be diagnosed with diabetes than whites. So when you consider these factors, any layering of utilization management that Part D plans to use on top of negotiation is going to hit Black and brown people harder.
Absolutely, yes. And what we're worried about is how CMS currently, but we have hope, has only pledged to monitor utilization management by Part D plans because we really think it's too passive. With the IRA's Part D plan restructuring changes, insurers are going to be responsible for 60% of costs in 2025, which is up from 15% today. So that's quite a jump for them. And we think it's more likely that payers are going to look to manage beneficiary costs more actively through the use of prior authorization and step therapy. Also, the IRA guarantees formulary inclusion for all 10 of the selected drugs, but it doesn't guarantee formulary placement for any of them. So if a plan switches formulary tier placement for a selected drug, beneficiaries might need to either pay more out of pocket to stay on it, switch to a preferred drug in the same class, or switch to a new plan. And so what I would love to know from your experience as a cardiologist, do these kinds of scenarios concern you?
Absolutely. I'm going to get into the nitty-gritty sort of, back of the house type of stuff, because I think that's where I can be the most impactful today. So we prescribe medications based on their direct knowledge of the patient's medical history, their life circumstances, and what's most likely to result in the best outcome for them. So Eliquis, Xarelto, and Entresto are a few of the medications that are on this price-setting list. These are also among the drugs that we prescribe the most frequently in our practice, and the ones we have to institute prior authorizations for, unfortunately. So what's concerning is that Eliquis and Xarelto are blood thinners that help to prevent stroke in patients with atrial fibrillation, in addition to other clot prevention measures. They are the medications we use first line because they are the best drugs by a landslide. They have the best safety profiles, the best outcomes, and nothing else comes close. They're life-saving medications, to be clear, and the alternatives are just not anywhere as effective. Along the same lines, Entresto is our first-line drug for heart failure. So utilization management complicates our ability to prescribe these medications and puts our patients in a precarious position as a result. The prior authorization process is not straightforward either. So you would think that when we prescribe the medication, you go to the pharmacy, you pick it up, it's a done deal. But when utilization management techniques like prior auth, which I'm going to harp on today, are instituted, when the person at the practice assigned this responsibility is usually a very busy medical assistant who's typically being paid minimum wage, by the way, or a biller at larger practices. And that takes the responsibility of prescribing the medication out of our hands and places it on our support staff. So in the meantime, you're at the pharmacy and they tell you, we're waiting on the doctor's office. What's actually happening is back at the office, this medical assistant is engaging in 3 to 4 back and forths with utilization management companies. Some of those happen over the phone, some of them happen through your electronic health record, some of them happen online, but they are juggling these prior authorizations for every single patient who requires it in the middle of doing everything else. We have a small team, and we have one person whose job it is to do all of these in addition to patient care. Wow. So you can imagine the load on that person, but the gravity of what they're being tasked with. Yeah. They are basically petitioning the payer to get the drugs that we are prescribing in the patient's hands. And you can imagine that's also worse in some offices that are seeing predominantly underserved patients. They tend to be understaffed, and in many cases, despite their best efforts, this prior authorization doesn't go through, it's denied. And we often don't find that out until the patient returns for follow-up. Oh, wow. So if you can imagine you prescribe a medication and you see the patient 2 months later, you don't know that that medication has not been approved. Typically, those notices come, the patient may get a letter in the mail. I don't even open my mail, or through a fax. We all know where faxes end up. So we often don't know. So it's already difficult to institute a plan of care in populations that are challenged by socioeconomic status. Every layer of utilization management adds a barrier to care in our most fragile patients. And like I can't emphasize enough that this is life-saving care. These are not novel drugs. And older adults have spent their whole lives paying into Medicare, so they deserve the same medications as everyone else. So my sincere hope is that CMS institutes guardrails to prevent utilization management from rationing the healthcare that's so devastating to our patients who are in the most need.
Yeah, well, I appreciate that. Is this like a daily struggle that you deal? Mm-hmm. Yeah, interesting.
Yeah, my medical assistant, whose day ends at 5, called me at 6 about a prior auth last night because she was still running through them to get her day finished.
And then I know that when we spoke, you said that you all try to do your follow-ups sooner because you know that
for this exact reason. Because when I prescribe a medication, I have no idea if it's going to get in the patient's hands for coverage reasons, prior auth reasons, a whole host of reasons. So I see them back almost immediately afterwards just to make sure that that loop is closed.
Is that the usual practice at most? How long do most people?
We have structured our practice so that we have room in our schedule to take time with our patients, but that is exceedingly rare, and it's a gift, and we have an advantage in that regard. Most practices are insanely busy. And I've been in practices where I was booked up 6 months in advance, so I didn't have the leisure of seeing my patients back quickly. I just had to sort of try to train them to say, look, if you can't get the medication, please call me immediately or send me a message.
Yeah. I know from my own experience taking care of my mom, older adults recognize the medications they take. So if something switches color or shape, they see that and they're like, I don't know if I want to take that. That doesn't look familiar to me. So it's important that CMS recognize those issues. So it's clear to us anyway that CMS has a lot of work to do to prevent Part D and Medicare Advantage Part D plans from setting up barriers to access and equity on the selected drugs to the point of abuse. We just really want to make sure that it's not overdone, and I think there is a high risk of that. So Dr. Collins, thank you so much for sharing your valuable insights and for being with us today. And I'm going to turn the program back over to Sarah and to Bob Cusack. Thanks so much for having us.